Good morning, very good morning.
Good morning, good morning. I'm so sorry I couldn't make it.
Good morning, Dandekar madam. Can you recognize me?
Very good. Hi, how are you?
Fine.
I'm so sorry I couldn't make it. I will definitely try and come some other time for some other occasion.
We were waiting for
I know. तो वही नहीं था कल शाम तक कुछ मीटिंग थी and then I couldn't possibly leave. It's about 3.5 hours to reach. But you have something in medical education there, and you will come to conduct a workshop.
Sure.
So should I share my slides?
Yes.
And if someone will introduce me.
So, Sucheta Dandekar madam, he was the professor and head Government Medical College, Mumbai, that is the Seth GSMC, as well as nowadays she is Professor of Biochemistry in Medical College, and she has published so many research papers. As well regarding to the research, she has done so many works, so many papers, as well as nowadays she is doing a lot of work on the medical education also. So madam is eminent professor, researcher, all this. So I hope I will wish to madam, please with the help of your research experience to give few things regarding to the topic of this one from bench to come to translating basic research. So a lot of thanks, a lot of welcome for us. Thank you, madam. Please.
Thank you so much for having me at your conference, and I wish your conference the very best. I'm sure it has been a big success. I've been looking at some of the photographs that have been put in the group, and I have been missing all of you personally. But this is my topic, from bench to community, translating basic research into relevant health outcomes. I am a strong propagator of whatever we do. Of course, everything we do be translated into research, into an outcome. But we should try our best to see where and how we can touch the public at some time or the other. So, what are the different types of research? One is the basic science research, which provides the foundation of knowledge for the applied science that follows. Then we have clinical research, which determines the safety and effectiveness of medications, devices, diagnostic products, and treatment regimens. We have community and population research, which characterizes and explains and influences the levels and distributions of health within and across populations. We have health services research, which studies access and consumption of healthcare services, focusing on utilization, cost, quality, delivery, organization, finances, and the outcomes. And then there is the translational research, which applies findings from each type of research which I described above and translates it to the next stage. It takes it a step higher. For example, we can take it from basic to clinical, or we can take it from clinical to community, or we can take it from community pulled up to basic research. Because community needs something, we will build something for them as far as the basic research is concerned. So that is the fundamental of all types of research that I have mentioned. How do we then translate the new treatments and prevention strategies effectively? You have laboratory-based research, which will get translated into patient-centered research, which will be translated into delivery to the patients and the community. But at the same time, the patient in the community will go back or you will realize कि ये चलता है, ये नहीं इतना अच्छा रहा, ये इसके लिए calibration चाहिए और ये from where can we get the calibration? So always we will have some feedback from the community. That is what is needed. You get a feedback from the community, and then again you go back to our feedback loop, and to try to find out again, to redoing, to reassessing ourselves, and to find out how the laboratory can still work further. So that is the whole fundamental about how we can translate the research. And so you have the bench to bedside, that is one aspect, and then you have the bedside to the community. That is the other aspect. Where, and so many aspects we have to look at, the barriers, the feasibility, what strategy will you use, what is the effectiveness. All this we have to keep in mind when we translate the clinical research to the health populations. कि ये गांव में चलेगा कि नहीं चलेगा, ये urban population में चलेगा कि ये rural में चलेगा. And when my device is going to the rural area, is it going to work with the network facility? What can you do, or can we keep the data in a particular device, and can we then look at it later on when there is not connectivity? So many aspects all of us have to be thinking, and fortunately for me, since I come from the city of Mumbai and IIT Bombay is so close to us proximally, geographically, we took advantage of the IIT Bombay, and we did a lot of work related to the devices and to biochemistry. So I feel very happy that I could achieve such things. So you have the basic research, the translation to the patients, to the practice, so you have the phase 4, and then the translation of to the community which is T4. You will notice everywhere, being a biochemist, I just love my arrows, the unidirectional arrows and the bidirectional arrows, and you will notice here that there are everywhere there is a bidirectional arrow, showing that एक अगर थोड़ा आगे जाओगे तो थोड़े पीछे मुड़ के देखना है, and you have to search and you have to see what else happens. So, without diagnostics, let me tell you, medicine is blind. And this was so well put by Alan Murray way back. So what is driving innovations in health now? What is it that is actually working? It is the devices, it is digitalization of healthcare, it is the rapid evolution of science and medicine, and it is also, of course, the unsustainable rise in costs. So everywhere commercially, whether it is your college, or whether it is the institutes, or whether it is the lab, the commercial lab, everyone is trying to cut costs. Sorry. And that is why people are trying to make devices which maybe will work out cheaper, and trying to formulate them and trying to calibrate them. So, as End Health Alliance explains, the ubiquity of mobile devices in the developed or developing world presents the opportunity to improve health outcomes through the delivery of innovative medical and health services, which furnish information and communication technologies to the furthest reaches of the globe. And that is what all of us are trying to do. And this COVID pandemic has taught us better than ever that this is how we can help the community, and digitalization and communication through technologies is the way of the hour, and it is the way to go. So you have telemedicine. I'm sure all of us have, hubs. It's not television, but telemedicine hubs. But maybe KGM has a hub. I'm sure KGM has a big there. So KGM has a telemedicine hub. So many people are there where colleges will have a telemedicine hub. And those who do not, they can be a part of the telemedicine hub, because then you can communicate. Then you have the mobile health, wireless communication and security protocols. And of course, there is the e-health. So many of the doctors consulted using phones during the pandemic, because they could not meet their patients face to face. And that is what we have seen over the years and over the time. And we must remember that India is the world's second largest mobile phone manufacturer after China. And 11% of global mobile population occurs in India. And it is the world's fastest growing market for mobile applications. And Samsung, the electronic company, actually put up a factory in India. And the factors that will ensure the market remains on an absolute upward curve, and we have to take advantage of this situation. So, e-health is the mantra now. And what are the dimensions of e-health? Improving the acceptance of e-health is also there. We must have readiness of users. We must have credibility of healthcare providers. There has to be a usability. There has to be a perceived usefulness. There has to be user privacy and data security, and integrity of the correctness of the data, and of course, cost effectiveness. I always say that ultimately we are also catering to patients who are poor, and we need to see that their costs are kept as low as possible. So smartphones are revolutionizing medicine. I'm not going to read every line that is there in that slide, but you need to realize that it is the smartphone that is going to now come a long way and is to help us biochemists also for diagnostic purposes. So what is the continuum of the M-Health tools? You have the measurement, you have the diagnostics in the form of point-of-care devices, portable imaging, biomarker sensing, clinical decision making. Then there is the treatment, chronic disease management, and of course there is the whole thing is going global. So you have disease surveillance, medical tracking and safety, prevention and wellness interventions. So all this is part of the whole gamut of health. I see a number of students out there in the hall, and that is the reason why I decided to talk all this, because these are avenues that are going to open for you as far as job applications are concerned. So you will notice that so many of my students have now gone on to companies which are now making devices. So, this is one aspect and one avenue that all of you students should remember, that this applicability, and that is the reason why all of us should become tech savvy. And I think I have also tried my best to be as tech savvy as possible and to learn. And my students have taught me a lot as far as this is concerned, the technology is concerned. So what do we have? You have similar decentralization of the labs will occur slowly, and that is happening already. You have single sample analysis, and you have the benchtop diagnostic devices, which will go into automated multiple samples. And then there will be the point of care testing devices, which will be acted on by the basic bedside care. And you have the chip and the nano diagnostics that are there, and then the e-diagnostics, which will involve real-time monitoring and integration with the smartphones. So this is how our labs are going to change slowly, and they have already begun to change. And you will notice that now you have small collection centers, and everything goes to one big large lab where you have multiple sample analysis. That is happening, and slowly in the rural area you will have point of care testing devices that will be available. So a revolution is taking place. There is an introduction of POCT in the healthcare has resulted, and you have more resource for laboratory-free testing, minimizing of risk, self-reliability of patients for self-monitoring, reduced turnaround time for actions by health practitioners. Of course, the patient expectations are there, and there are quality concerns, and that is the reason why you can't say every year point of care testing is made, no, we need to see that it gets calibrated. We need to see that this patient every 3 months or 4 months brings it back to a hub or sends it, couriers it to a hub where it can be calibrated again once more. Or you have certain strips which are calibration strips which are available to him and can be bought out off the counter, and then he or she can use them so that they calibrate the machine. Otherwise, all this point of care testing devices are all futile, and they are not going to be of any help. So healthcare economic strategies are also important. So this is what Christopher Price said about point care of testing devices, and we have here the provision of a test result at the point of time near the care of patient, at which the result will be used to make a and take appropriate action which will result in an improved health outcome. So this is what this is the definition of point of care testing, and this is what is actually happening. You have a quick quality evidence, you have the information, there is a decision, there is an action taking place, and there is quality management which will be done due to the outcomes. So this, in brief, is what the efficacy and efficiency of devices will mean. So, all point of care of devices should follow the acronym ASSURED: affordable, specific, sensitive, user-friendly, rapid, robust, equipment-free, and deliverable. This is what the acronym says about point of care testing devices. And these are the existing diagnostic practices in point of care. You have the point of care devices which are simple to use and high performance, which are, the example is the lateral flow and the microfluidics, which involve a lab on chip or a lab on stem. Then there is the nanotechnology. I'm not going to details of each one because it will, I was given only half an hour, so otherwise this normally is a 1 hour lecture, but I have sort of brought it down to half an hour so that as long as I tell you what all is there, I think it's enough to sensitize you into what all are the mechanics. There's the lateral flow assays, there are the microfluidics involving a lab on chip and lab on scan. Then there is the nanotechnologies and the biodiagnostics, which involve gold nanoparticles, magnetic nanoparticles, magnetic gold nanoparticles, and carbon nanoparticles, all of which are used, and IIT is doing a lot of work using nanotechnology. So you have the mobile POCTs also, and have the single channel detection. And then there are the wearable devices. You see so many apps now. So fingerprint डालो और तुम्हारा BP समझ में आएगा. You just put your finger and you know what your blood sugar is. So this is how you have the ECG monitoring system. You just wear a device and to tell you what to do. So, mobile health is also important, but there are barriers to mobile use. Now has it got taken over? Now having the labs closed down. Now isn't everyone just said, "Acha, abhi ye chal jayega. Abhi band kar dete baaki sab." Because what are the challenges? Less controlled testing environment. There are pre-analytical variables that have to be looked at. Specimen reagent controlled degradation occurs. Effective sample matrices occurs. And there is limited current operator training, let us say. That means all of us and the patient also should know how to use the device. So he has to have enough knowledge and enough understanding and enough expertise. So that is the problem in these devices. So I'm not saying that everything is still in good order. So what are the suggestions to overcome the barriers? First of all, we need to focus on basic laboratory methods and quality control. Quality assurance has to be there. Information recording and transfer has to be there. Normal and abnormal laboratory values as per the device have to be, reference values have to be revised. And of course, problem recognition has to be there. The patient should realize कि ठीक नहीं चला और I'm feeling absolutely alright कि मेरा sugar क्यों दिखा रहा है 400. So, he should realize that something is gone wrong with the device and not panic. So, these are things that we have to see. And the quality control in POC. Is the sample adequate? Are the test results trustworthy? Do you have control over the procedures? Do you know if you did something wrong? Is the test performed correct? Is the information right? All these are questions that you will ask each other when you do point of care testing devices. So you have the instruments, you have the data management, you have the server on which all the data will go, you have the lab information, and you have the hospital information system. All this will be in flow together. So there are many pointers that will be considered while developing new diagnostic devices and technologies, which I have already talked about. So I'm not reading this slide. I hate crowded slides. I'm sorry for this. So what we did this using a validation of a bone nanoparticle-based POCT device for management of renal disorders with the IIT Bombay. And they also had a partner with some other agencies, and they tried to make this device, and we tested it at Kenya. A cost-effective and semi-quantitative bedside screening for early detection of renal injury. And this is what we found that, of course, there is a 11% rise in renal failure, and we needed a sensitive, early, and affordable diagnostics device which could be put into the market. And then this was the opportunity that we had, and this is what we actually saw as far as the current renal diagnostics injury was concerned. And there was bedside screening was absolutely not done, and that is the reason why this device helped solve the problem, because it was this ultra valve, which was affordable, sensitive, and specific. The turnaround time was only 2 to 5 minutes. It was quantitative, early detection could be done, and it was a bedside device. So this is how it helped. Very much similar to your home test, to your pregnancy test, etc., etc. So the device, just a few drops of the urine sample was used, and we could do this as far as the amyloid sample is concerned. And we saw that it was affordable, and this and there was no news of no reaper at that time, and 5 to 15 times more affordable. And the device cost only about 3,000 rupees. So there was a good affordability. And what did we do? There was this device optimization, because throughout the trial we were running the samples to say any chala. So again they would go back, redo the sample. Then we did a method validation that which chemical works the best for them, and which strip works the best for them, which gel works for them. And then we did all that, and finally we reached the stage of clinical validation. All this was sent to the ethics committee, and all the devices had an ethics committee sanction. And then we also worked on a point-of-care testing device for hemoglobin installation. And this was also well sought out. And there was this, this IIT Bombay, these students, they passed out the engineer, and then they put up their own startup company. And they started what was known as a prenatal care of high risk, antenatal care kit they produced. And they had the hemoglobin analyzer, thermometer, blood pressure monitor, fetal Doppler, weighing scale, digital stethoscope, urine protein analyzer, and a blood glucose monitor. All this was part. See how the students worked on it. And in fact, they got the Pradhan Mantri award also for this. And this is like trying to reach out to the pregnant women in the rural areas. And we taught, we went into the community. That is why my title of my topic is From Bench to Community. The guys, and the people who were in the back of the rural community were, they were taught how to use the health workers, and they were taught how to use it, and they were given this kit, and they were happily taking it to all the doorsteps, to the pregnant women, to their houses, and they sort of able to detect so many of the high-risk patients using the care and other monitor. There was this increase that was seen, percentage increase. We also worked in the Waynard slum, where we tested these devices, and we saw that over time there was this rise in the registrations. And this study is continuing, but I don't have the recent data. We also did it in the villages near Aurangabad. So all this just kept on happening. But what is the crux of the whole thing, or the center point of this whole thing is that the patient empowerment is necessary. What is patient empowerment? Means we have to tell the patient a process in which patients understand their role, are given the knowledge and skills by their provider to perform a task in an environment that recognizes community and cultural differences and encourages patient participation. Here the patient also has to be monitored, has to be motivated, and that is why my topic says to the community where the patient is also involved. So patient empowerment is there. Well, how do we empower the patient? If the patient gets enough knowledge to be able to engage with their provider, they understand their own role, they hone their patient skills, and the presence of a facilitating environment should be there. Because Arabic will go there and they will help. The Angari workers will go there and they will help. And they will tell what to do with this device. So, you need to train the healthcare providers in the art of communication. So, what are the thoughts? What are the good points about this? There is improved knowledge and improved precautions and awareness. There is process of being informed and involved, and it could be to a better trust in the healthcare system. And of course, it is cheaper. But of course, there are more problems to solve. Content is automation versus affordability, accurate diagnostic tools, differential diagnosis, whether we can do it with the devices or not, diagnostic costs, sustainability. All this is an important topic to be thought of. And then, of course, the health centers. Each health center must have effective monitoring tools and, of course, critical care solutions. You can't just let the patient think, ये ठीक है कि नहीं ठीक है. You have to have someone who you can talk to and say, अभी मैं क्या करूँ? How can I be helped? So remember, wherever we go, whatever we do, the patient is at the center of everything. There has to be convenient access. There has to be a focus on wellness and disease prevention. There has to be personalized care plans. There has to be support and resources for healthcare, self-care, coordinated healthcare, and of course performance improvement. All this is an important aspect. So we believe, again, stream surface, we believe consumer health technologies, apps, wearables, self-diagnostic tools have the potential to strengthen the physician-patient laboratorium connection and improve health outcomes. So with that, I end what I have to say. I'm ready to take any questions, but you must remember that we will never ever succeed unless we keep Rudyard Kipling's poet in mind. I keep 6 songs serving them. They taught me all I do. Their names are what and why and when and how and where and who. Unless we keep asking our questions, these questions time and again, we are not going to succeed as far as research goes or as far as anything in life goes. So, but also remember, Albert Einstein said this, anyone who has never made a mistake has never tried a thing. So, don't be afraid, just go on and keep on working and be happy with what you do. The secret of going ahead is getting started. So please remember what the great scientists and what the great Nobel laureates, they achieved everything because they did do anything. They did do everything with a lot of fervor. I would like to thank Bernard Bouguet from France, whom I have worked with and who was kind enough to lend me a few of his slides in the beginning on mHealth. And of course, the IIT Bombay School of Sciences, which got our department and our lab good enough to do the work with them. So thank you so much. And this is my present era Lucknow Medical College, from where I am taking the lecture just now. So with that, thank you. I will stop sharing my slides now and leave it with you all.
The question is there, then you can ask.
Oh, this is to be lost in the auditorium.
Right now,
How's the game?
Sudhir sir. Sudhir,
old friend of mine. I was so young. Any questions?
No ma'am, thanks. It is a nice lecture, everything was crystal clear. Everything was crystal clear, madam. It's a nice lecture.
Thank you so much.
Nice, thank you.
Thank you so much.
A lot of thanks, madam. On behalf of organizers, by Dr. BIOCHEMISTRY, a lot of thanks. So, you have
Thank you, thank you.
related to this one. Thank you, madam. A lot of thanks.
It is the next.
Next paper, Professor